Good. So let me have the chat box open as well. All right. Assalamu alaikum, everyone. Hope you're all doing well. Well, inshallah, you guys will have an easy exam. You'll get an A's. You'll get A's. Just gonna be a quick pharmacology review. This is adapted from the slides used last year, Ibrahim and Momo's, and then I just kind of added on to it and expanded a bit. Inshallah khair. If you guys have any questions, you can always ask in the chat box or just unmute. It's fine. I want it to be a little interactive because, it's question session. So I don't want to just read the question, answer it, and then move on. I'll also kind of talk a bit about how to approach these POD questions because, you guys POD is a bit of a different block. So you want to have a good idea of how to read these questions and understand what the question might want from you. Because, with POD and further on to third year, a lot of things become a bit more memorization based and less critical thinking. There is critical thinking, but it'll be in a kind of different way. First year, you're going to be asked, you're being asked physiology questions, things like that. Now you're going into pathology, pharmacology, immunology. So it's a bit different. So first, let's just start off with a question. First of all, you guys can see the slides, right? You guys should be able to see the slides. Okay. So A, all right, linezolid. Hang on, sorry. All right. So linezolid, yes. Can anyone tell me what B does? Chloramphenicol. Since we have low attendance, it binds to 50. Yeah. And then C, what does C do? Also binds to 50 as well, yes. So D is also binds to 50S. And what, the reason this question is actually, it's from the previous PowerPoint. And I changed the question a bit because if you'll see in a bit that actually I think B prevents initiation, but it's not their main mechanism of action. Okay. What you should know though, linezolid, the main mechanism of action is the initiation complex. B is more for elongation, and then C just inhibits translocation, and D is also inhibits translocation. So just someone tell me what is the contraindication for using linezolid? This is something they might ask you. Contraindication, or maybe tell me what's the side effect of linezolid? If you know the side effect, you know what it does, you can start thinking of contraindications. So the problem with pharmacology. So thrombocytopenia is one of them. Okay. Actually, I'm not too sure about it. I'm looking for one thing that's thrombocytopenia might be it, but one thing that I want to know, a contraindication. It has to do with other drugs. If you're taking a specific type of drug, what drug can you not take with it? So SSRIs. Why? Because linezolid is considered an MAOI inhibitor, a monoamine oxidase inhibitor. So if you take SSRIs, which uptake serotonin, and then linezolid also kind of does the same thing because it inhibits monoamine oxidase. This is something else, the actual mechanism of it, I don't want you to worry about. But I want you to know that if someone's taking SSRIs, which is a treatment for depression, and they also take linezolid, they'll develop something called serotonin syndrome. So you have to be worried about that. So before you start them on linezolid, look in the question stem. Maybe, they might try to trick you and say this person is taking SSRIs. You would want to take this off your options, linezolid. Okay. It's a little trick they use. Okay. So this is just a quick little figure of, the different drugs. And you see how I was saying, so this right here is the initiation complex, right, on the 50S. You see how macrolides and clindamycin also can go here, but it's a dotted line. That's because it's not its main mechanism of action, but it can inhibit initiation. But if it's a straight line, it means that this is the main mechanism of action. So linezolid for initiation on the 50S, okay? So anything on the left is the initiation phase, and anything on the right is the elongation phase. I know you guys studied this, but I just want you to quickly take a look at it so that we can answer the next questions very easily. Anything on the 50S, so let's see, we have aminoglycosides. So not only does linezolid affect the initiation phase, but so do aminoglycosides. Okay, so any aminoglycoside also affects the initiation phase. Everything here on the right is going to be, they have their own little things. For example, macrolides and macrolides, they go on the elongation factors. So does clindamycin. Prevents elongation. I don't think I should go through all of these. I think you guys have read it already, but just use this for reference. This is on Amboss. It's also on these PowerPoints. I think it's a nice kind of recap of the different mechanisms. And you guys should know the mechanisms better than me. I know this by heart, okay? Because they like to ask about these things. They like to ask, these little factors. For example, which one's the main mechanism of action? Which one does this? Which one does that? Okay. Let's go through some more questions, more clinical things. Which of the following side effects here is fatal? C, chloramphenicol for aplastic anemia. Okay, what about vancomycin? What does vancomycin do? Redman syndrome. Yes, Redman syndrome is the side effect of vancomycin. It is not fatal because it's treatable. Clindamycin, what does clindamycin do if we take too much clindamycin? Hearing loss as well for vanco, yes. Clindamycin, colitis. There you go. And then, yep, perfect. Okay, so you guys got it. So, the reason aplastic anemia is fatal, I'm sure you guys know what aplastic anemia is. Essentially when, all your cells in their body is low. And this is very bad because you can easily die of any infection because you have no white blood cells. So your body cannot protect itself from these severe infections. Okay. So that's why aplastic anemia is considered a very serious adverse effect. And it's generally fatal and it's very hard to treat. So this is why, this is something you always want to keep a lookout for clinically. Okay. Which of the following is the correct mechanism of action for ceftriaxone? B, right. All right. Just quickly, what is A? What drug are we talking about for A? Vanco would be C. Okay, actually, I see what you guys mean by you're thinking it's A. So C is more of vancomycin. A is penicillins. Okay, penicillins binds to the penicillin binding protein and inhibits the polymerization of peptidoglycans. Ceftriaxone inhibits the cross-linking. Vancomycin binds to D-ALA, prevents the cross-linking. And then for 50S, inhibits protein elongation. That's like chloramphenicol. Okay? Ceftriaxone is a third generation cephalosporin. So for the cephalosporins, there's a lot of different cephalosporins, right? The ones that you should really know and you should be familiar with the name is ceftriaxone. Ceftriaxone, in my opinion, for these exams, is like the most important, most important cephalosporin to know. And there's a nice table about it. Jude's asking, how is A penicillin? Well, I have it here in the notes from the previous presentation that this is penicillins. Why do you think it's not penicillin?
Because we didn't take that it inhibits polymerization.
So what did you take? Let me do a quick search on Amboss just so I'm not giving you guys anything wrong.
I remember it was for cross-linking, the last phase of cell synthesis because it attacks PBP, which is cross-linking. Polymerization, that word was with vancomycin. That's why I got confused.
Binds to D-ALA and it inhibits peptidoglycan polymerization.
Okay, during our break, I'll look it up on Amboss and get you the actual thing. But I'm going off the notes from last year, and here they have it as mechanism of action for penicillins. I'll get back to it, inshallah. Okay.
Thank you.
It is important. You guys are right. They like to you see how tricky the words are here. So it is important to know this. So I'll find out for sure and let you know, inshallah. Thank you for catching that. Okay. 25-year-old female with a history of sexually activity presents with vaginal discharge and painful urination. A swab and culture was done, and the patient was diagnosed with chlamydia. The patient was started on appropriate pharmacological therapy, and 1 week later presented with sensitivity to light. Which of the following drugs do you guys think the patient was put on? So photosensitivity, right? That's what sensitivity is, light. What do you guys think is the drug? Okay, linezolid, minocycline. So B is correct because it's a type of tetracycline. Okay, tetracycline is well known to cause phototoxicity and other things such as, like, vomiting, nausea. You can cause dose-related ataxia. Okay. If let's say tetracyclines was not an option, and then we didn't see the we didn't see the sensitivity to light. What other drug could be given for chlamydia? Does anyone know? I think you guys should know this since it's in micro. You can either give tetracyclines or another class of drugs. If any of you watch Sketchy, you should remember, macrolides, the birds. Okay, so remember, in chlamydia, you can give tetracyclines or macrolides. Specifically, photosensitivity, usually look at tetracyclines. All right, now let's quickly just talk about how do you approach these questions, right? You see these questions and, you see these drugs, you're thinking, okay, I don't want to get tricked, because the thing with pharmacology, you can easily be tricked. This one is not as tricky as the future questions I'm going to show you, but just in general, when you read, okay, look at some things. First, you want to look at what do they have, right? So here it says, it's very easy. It says chlamydia, so you know that they have a STI, and it doesn't say the drug name, but then it gives you side effects. So this question is one of the less tricky questions, because it's not asking you what drug do you give, it's asking for a side effect. And we'll talk about more of the hints when it talks about what drug do you give. But here, I think it's very straightforward. They give you photosensitivity, and then it's a very simple recall question. Okay, what drug is it? And some of you might have not known minocycline is a tetracycline, right? And I remember in my POD block, this was one of my problems, is I would know, like, okay, I know tetracyclines are photosensitivity, but when the exam comes, it gives me like a drug, which is like, okay, gentamicin versus azithromycin. Oh, which one was this? Which one was that? So, before you guys go into your exam, I want you to really make sure you read from your slides, because you see there's so many different drugs that there are, but you want to read from your slides which ones are mentioned so that you memorize those ones. Don't memorize all the external drugs that are the same class, only the ones that are mentioned in the lecture. Memorize them, memorize which ones are under which class. This is something that I really consider when I took my exam. Does anyone have any more questions for this? Okay, if you have any questions, just ask me. Okay. And I already said the unique adverse effect for minocycline causes dose-related ataxia. Ataxia means they lose balance. They have a hard time balancing themselves. Chelates with calcium, yes, that as well. And that's actually the next point here, is this chelation with calcium could cause, you have these kind of hypoplasia, so the gum kind of looks like it's retracted. And this is kind of what the photosensitivity looks like and things. So if you see a picture like this in your POD exam or your POD OSPE, I think it's just, you guys have your med term coming up, so you're not going to have an OSPE. But this might also come in your MCQ. If you see anything like this, usually it's tetracyclines, okay? The nice dental staining here, and then the gum kind of being hypoplagic, so it's kind of retracted. All right, next question. 52-year-old male presented to the hospital a week ago with a lung abscess and was treated with the appropriate pharmacological therapy. The patient was kept in the hospital a few days later. He started having watery diarrhea with pus in his stool. What is the next step to treat his condition? First of all, who knows what's happening to this patient? Infection, treated an infection in the hospital. They developed diarrhea. Yes. Yeah. Okay. So A is what exactly? Is A the answer? Because A is not the answer. A is the reason that the person has this presentation, which is pseudomembranous colitis. So see, this is why pharmacology questions can be very tricky. Make sure you read the question very, very well. It doesn't say what was the patient given in the hospital. It says what is the next step to treat this patient. The patient has pseudomembranous colitis because he was given clindamycin. Just know, any question where the patient is in the hospital being treated for any infection, just any random infection, and then he develops diarrhea with pus or mucus, just assume pseudomembranous colitis. And then yes, the treatment for pseudomembranous colitis is oral vancomycin. Do you understand? Why don't we give IV Vanco? Yes, the only time you give, yeah, it's a bit of a tough question, but this is why I really want you guys to because I know you guys know this information. I know you know that pseudomembranous colitis causes hospital-acquired infection after clindamycin abuse. So you need to really use some critical thinking here. You see a patient with an infection, the infection gets treated with a drug, and then the patient just develops diarrhea. You have to think, okay, this is pseudomembranous colitis. Even outside of your POD final, you're going to see a lot of these same concepts, pseudomembranous colitis. You got to really hammer it in your head, okay? So you got to know, pseudomembranous colitis, its most common presentation is just watery diarrhea with pus or mucus, okay? Is there any questions about this? All right, let's move on then. Guys, if you have any questions, please. So yeah, oral vancomycin, not IV vancomycin. IV vancomycin is given in every other situation, but this is the only situation where oral vancomycin is given. And if you remember your sketchy picture, okay, guys, your sketchy picture, you have oral vancomycin here. This is the VAN for oral vancomycin. Another thing I want you to know, in actual clinical practice, the treatment for pseudomembranous colitis is metronidazole. Or sorry, no, it's oral vancomycin, and another option could be metronidazole, which is the nice metro here. I don't know if you guys took this, but just know you have two options in this type of question: oral vanco and metronidazole. All right. Yeah, sure. So which of the following antibiotics is associated with a high incidence of nephrotoxicity? Also, guys, if you see any questions in the actual, or sorry, any words in the actual question that you don't understand, feel free to ask. Okay. Some of you are saying C, vancomycin. All right. All right. So everyone thinks it's C. Yes, it is C. It's vancomycin. All right. So you have isoniazid. It's mostly hepatically excreted. Actually, don't worry about these. What I want you to know here, okay, vancomycin is correct. It has a high incidence of nephrotoxicity. Can you guys tell me another antibiotic which has a very high incidence of nephrotoxicity? Yes, aminoglycosides. So you can never combine these two drugs together when you're treating a patient, or at least if they have some kidney problems, you really want to avoid it, because if you have both, it's gonna make it even worse, and then this could cause a lot of kidney damage. So one question could come and tell you, oh, this patient is they're taking vancomycin for pseudomembranous colitis. They've developed this other infection. What drug can you not give them? Aminoglycosides. Okay, just remember that aminoglycosides with vanco is bad. Don't forget that. Any questions here? All right, thank you. Guys, if I'm being too quick, if I'm just please let me know, okay? So this is just a nice little table I put for you guys of, the drug metabolism. As you can see, the renal ones are here, hepato are here. A nice thing I want you guys to remember is ceftriaxone is duly excreted, which is out of all the cephalosporins, it's the only one that is duly secreted. So if you have a patient who has renal failure, if your question comes and the patient has renal failure, and then they say, oh, which drug can you give them for a specific type of infection, whatever infection, ceftriaxone is safe in renal failure, okay? And if they give you other options that are only cephalosporins or penicillins, just put the ceftriaxone. Ceftriaxone in general is a very special cephalosporin, okay? Just keep remembering that. Ceftriaxone is usually a good answer in terms of nephrotoxicity or some sort of coverage. And then for this next question, this was put from the last year's thing. I think it's still in your slides. I'm not sure. So if you don't know it, don't feel bad. So which of the following drugs can be given as prophylaxis in surgery? And this is I'm not gonna lie, this is a trick question. It's two answers. Two answers are correct. If you don't know it, it's fine. Yeah, so this is the one time where I say, ceftriaxone is special, but it's not special this time. So D is one of them. It's cefoxitin and cefazolin. Okay. I don't know if you guys have the slide this year. I didn't delete it. I looked in your slides, I couldn't find it, but I didn't delete the slide just because sometimes the doctors like to put in old questions which aren't in your slides, and you never know. So just remember cefoxitin, especially cefoxitin. They like to give this drug just before someone goes into surgery, okay? If you didn't know it, don't panic. I don't think it's with you this year. I couldn't find it. Yeah, so sulfacetamide is used for burns. If you don't have this, then don't worry about it. I just thought to keep it in. Maybe you guys, maybe the doctor will be mean and put in this question. You never know. I didn't want to delete it just in case. So just cefoxitin, cefazolin can be used in prophylaxis for surgery. And it's here in the slide from last year. So if you didn't know it, don't worry. Okay, so can anyone tell me why do aminoglycosides not work on gram-positive bacteria? Yes, exactly. So gram-positive bacteria, no porins. That's all it is. So how do you think they would get mechanism of resistance? If there's no porins, how could they have a mechanism of resistance? You give another drug, yes. So to combat the resistance, you give another drug. What drug do you think you give? Beta-lactams. And is this considered an additive or synergistic effect of synergistic? Yes. So I just put a quick little picture here. Here's your gentamicin. Okay, it can't go in because there's no porins. You give a cell wall inhibitor, you've just opened up the porin. Now the gentamicin can come and do real damage. This is considered synergistic effects. I think you guys know this. Just remember, aminoglycosides and beta-lactams can be synergistic. Okay. So next question. A 27-year-old woman with a history of intravenous drug abuse is admitted to the hospital for fever and shortness of breath. Multiple blood cultures are positive for Staph aureus with resistance to methicillin. Which of the following is an appropriate antibiotic? Okay. Okay, nice. Yeah, so this is not very tricky. MRSA, give Vanco. Okay, thank you. Good job. It says here Vanco is a drug of choice for serious infections such as MRSA. In endocarditis, you give it for 6 weeks. I don't know if you need to know that. But yeah, you can just read this on your own time. But if you know Vanco for MRSA, I think that's all you need to worry about. Okay, after being hospitalized and treated for pneumonia for 2 weeks, a 32-year-old man developed a bacterial infection. After culture, it was found that the man had an enterococcal infection. So treatment with vancomycin was started. However, his symptoms persisted. He was started on quinupristin and dafapristin. What is the purpose of using dafapristin in this case? To cover for MRSA and VRE simultaneously, okay? Any other options? C, as a synergistic effect. A. Okay, so again, C is the correct answer. However, A is also correct, but it's correct technically. But in this question, they were looking for what is the purpose of using dafapristin. So when the doctor added dafapristin, this is why pharmacology can be tricky, right? They like to play with words. This is not a question I made up. Like this is a question from one of the question banks somewhere. So this is sometimes how they ask questions. So you really have to think, okay, what are they asking? What is the purpose? Is because dafapristin, what it does is it binds to the 23S portion of the 50S ribosome and it changes the conformation. And this causes the binding. Yeah, exactly. Exactly, yes. Increases the binding of about 100 times more. So see this 100 times more binding. Obviously, that's the main reason they added the drug. Okay. So yes, it does technically cover MRSA and VRE, but that is not the main reason or the purpose for using dafapristin in this case. All right. Do you guys understand? All right, perfect. If you guys don't understand, please just ask me. I speak very fast. It helps cover vancomycin resistant bacteria. But in this case, it helps, if you're talking about the drug helping something, it helps the quinupristin. Dafapristin helps the quinupristin mostly, but it does help cover VRE organisms as well. Okay. Also, just one thing you should know, if someone had MRSA and VRE at the same time, they'd probably die. All right. Let me ask this. All right. A patient on renal dialysis developed a staph. Yeah. A patient on renal dialysis developed a staph infection 2 weeks ago and was started on a penicillin to cover for the appropriate microorganism. Which penicillin was used in this patient? Okay. So 2 people say D. Okay. Yeah. There you go. So very simple. Anyone have any questions about this? So nafcillin is the only one that is eliminated through the bile or through the liver. So there's not really much of a trick here. For those that didn't remember this, the way I memorized it, it's a little stupid, but like nafcillin is the only cillin. So enough of being like everyone else. So it decided to go through the hepatic route. All the other cillins go through the kidneys. Okay. And this is just a quick slide for it. All right. A pregnant lady came to a prenatal checkup when she was 2 weeks due to her date. The doctor did a routine vaginal swab and she was positive for group B strep. The doctor reassured her and gave her a prophylactic medication. Which one of the following was given? Say your answers. Group B strep, what's the treatment? Now, I know you guys are thinking of one specific drug because this was the drug in Sketchy. You can say that as well. Did you guys take the treatment for Group B strep? Okay. You haven't taken Group B strep or strep agalactiae? It's a pretty important thing. Okay. So just in general, penicillin. Okay. Specifically penicillin G. And so in this specific question, ampicillin is a type of penicillin with amoxicillin. And the reason they give amoxicillin with ampicillin is because amoxicillin, actually, does anyone know why do you give amoxicillin with ampicillin? So you give amoxicillin with ampicillin because it helps. So back to chart is a good attempt, but it's a bit more specific. It's just simply because it helps it absorb. So amoxicillin increases ampicillin's oral absorption. Okay, so that's why you give them together. In Group B strep, guys, you give penicillin G or just penicillins in general. Okay, if you remember, if you watch Sketchy, which by the way, for micro, I highly recommend you watch Sketchy. I know your exam is on Sunday, but if you can make some time, watch Sketchy. At least for the high yield bacterias, you can remember the pen in the Group B strep video. Okay. Does anyone have any problem with this? All right, we can move on. Oh, well, looks like it. Well, guys, I kind of spoiled the question, but which drug was given in this patient? So you can see I'm putting some easy questions and then some harder questions so you guys get an idea of, yeah. So A, vancomycin, red man syndrome. Yep. Can anyone explain what red man syndrome is? Like what's happening? Vasodilation overall. Yeah, so it's an anaphylactoid type reaction caused by mast cell degranulation, which is, yes, as Ahmed said, histamine release. Okay, so the histamine gets released, causes this whole degranulation thing. So just remember vancomycin, red man syndrome. It's very important, guys. You should really know red man syndrome. Okay, one of the high yield topics. All right, a patient presented with strep throat and was seeking treatment. Upon taking past medical history, it was revealed that the patient has a history of renal failure. The doctor would like to begin the treatment of cephalosporins, but is struggling to choose one. Which of the following is appropriate to give in this patient's presentation? Before you guys answer, or you can answer if you want. But let's quickly go through this question because I said, these questions are a bit trickier when they say which one should we give. So just some things you should look at. One, is the patient pregnant? It doesn't even say their gender, so we can forget about that. Two, what problems do the patient have? Okay, so let's see what problems the patient has. Patient has history of renal failure, strep throat. That's it. So we know strep throat, renal failure. Now they wanted to give us cephalosporin, but which one? Okay, we know he has strep throat and renal failure. You can choose the drug based off two things: what the patient has and indications, contraindications. Okay, so first you want to rule out any contraindications. Renal failure. Okay, now we know we have to give a drug that is not excreted through the kidneys. So which answer is that, guys? When in doubt, ceftriaxone. There you go. Yes. So ceftriaxone, the special cephalosporin, it's dual excreted. That's the answer. All right. I mean, I think that's pretty much all it is. Does anyone have any questions of why it's ceftriaxone? Basically, just generally, these are all renally excreted. This is dual excreted. Dual excretion means it goes through the kidney and the liver. Since the kidney's shot, it's just going to choose to go through the liver since the kidney can't even filter it out. Okay? Ceftriaxone, the special boy. All right. Which of the following two drugs cover Pseudomonas? Okay, one person says D. D, yeah. All right, perfect. Great, so D. So why not A? Exactly. Ceftriaxone doesn't cover it. Piperacillin does. In B, both of these, imipenem and cefazolin, they don't cover it. Amoxicillin doesn't cover it. Ceftazidime, zidim, and piperacillin do cover it. So that's why it's D. And then there's like this nice little thing here. So you have first generation cephalosporins. They're mostly gram positive. The more you go down, the more they start covering gram negative more than positive. Okay. Fourth gen in specific are for Pseudomonas, and then fifth gen is for MRSA. So, Pseudomonas is a pretty nasty bug, right? It does a lot of damage. So the way I just remember it is, gram positive bacteria, because it's just so common. That's why they were the first gen that was made. And second gen, they were just discovering gram negative. And then the more generations that went on, the more negative and more tough the bacteria got. That's how I memorize it. Okay. And then just, ceftazidime, I can't pronounce it, but you guys get it. All right. Anyone have any questions before we move on? All clear? I'm trying to be a bit slower for you guys because I feel like I'm talking a little fast. If you want, guys, we can go back to any question. If there was any question that was explained too quick and you have a question about it, just feel free to ask, or we can cover it in the end, inshallah. Okay. And if you guys have any questions outside of pharma, I'd be happy to answer. Okay, we'll just move on then. A 27-year-old man presents to his primary care physician with complaints of a painless ulcer on his penis. The patient admits to having unprotected intercourse 2 weeks prior. All right, we got someone answering already. Visualization of the lesion by dark field microscopy. Demonstrates spider sheets, and he is diagnosed with syphilis. The patient has no known drug allergies. Which of the following would be most appropriate in the treatment? Someone already says D. Does anyone say anything else? Someone says B. Okay. Someone says B. What class of drugs is a doxycycline? Tetracycline. Okay. So B is a good answer, but the answer here is D. In syphilis, you always prioritize giving penicillin. Okay. You always prioritize giving penicillin. And it's actually, so when do you give tetracyclines? Can anyone give me that answer? You always prioritize penicillins, but there is a case where you give a tetracycline. It's actually hinted in this question why you don't give penicillin, tetracycline in this question. Allergies, yes. So here the patient has no known drug allergies, okay? If they have no known drug allergies, this is why, guys, I'm saying, when you look at each question, look at first, what problems does this patient have? Painless ulcer on the penis. That's it. No contraindications. And also the drug, no known drug allergies. So no known allergies. Give penicillin because penicillin is the first line. Okay. In renal failure, since penicillin G is renally excreted, yes, you would go for doxycycline. I don't know if doxycycline is renally excreted. I can't remember off the top of my head, but if it's not, then yes, that would make sense. But what you should know is that doxycycline, you give it after if there's allergies. Now, there's actually one case where even if the patient is allergic, you still give penicillin. Does anyone know this? Neurosyphilis. Okay. If the syphilis has reached the brain, you do something called allergy desensitization. So you give a little bit of penicillin, let the allergy kind of calm down, and then you give the patient the full dose of penicillin. So that kind of gives you an idea of why penicillin is first line. Penicillin is the best way to kill syphilis, to the point that even if it goes to someone's brain and they're allergic, you still give penicillin. Okay. So don't choose tetracycline if you see it on the question, unless the patient is allergic. Okay. I don't think they're going to tell you, I don't think they're going to try to trick you that hard in saying neurosyphilis. So just always put penicillin. Unless they're allergic, just put doxycycline. Okay. Penicillin if they're not allergic, doxycycline if they're allergic. That's what I want you to know here. Any questions? All right, let's move on then. Yeah, again here, doxycycline for alternative treatment in penicillin allergic patients. Yeah. Okay, so I have a break here, but I feel like we did go a little quick. Do you guys want to take a break, or should we just move on? Up to you guys. We have about like 20 more slides. Okay, we can continue. We'll continue then. All right, 19-year-old man presents to the ER with a severe headache, photophobia, and a stiff neck. After a lumbar puncture, the patient is diagnosed with bacterial meningitis. Which of the following cephalosporins is most appropriate for empiric treatment? Go ahead and answer in the chat. Okay, one person says D, one person says C. If you've watched the sketchy video, try to remember the picture in the video. Any more answers before we reveal? Okay, so we have different, yeah. So empiric treatment, you know what empiric means? All right. So empiric means, just general, to cover as much as possible. So which of these do you think covers the most? Okay. Some are saying A, some are saying C. So the one that covers the most is generally ceftriaxone, the special boy. Okay. Ceftriaxone is in that nice sweet spot of third generation where it covers a lot of gram negative. It also covers some gram positive. So they like to give ceftriaxone. In the actual management of bacterial meningitis, you give vancomycin plus ceftriaxone. But in this question, they were asking out of just the cephalosporins. Okay. So just generally, third generation cephalosporin is good for. So cefepime for fourth generation. The thing is, cefepime in specific, you use it for targeting Pseudomonas. And in general, in pharmacology, you don't want to start giving cefepime when it covers the same amount of gram positive and gram negative as the third generations plus Pseudomonas. When you know that bacterial meningitis isn't really caused by Pseudomonas, why would you give a drug that can cover Pseudomonas when you know it's not Pseudomonas? All that's happening is you can actually increase the resistance of if there was Pseudomonas generally, but not infecting the person, you can cause resistance to that drug. or the bacteria that's infecting the person, since cefepime is not used as much. When you have higher generation drugs, you don't want to use them when they're not needed to be used, because that's how you develop resistance. You try to be as conservative as possible. That's why if someone has like pneumonia, you rule out viral pneumonia, because you don't want to give bacteria, you don't want to give antibiotics in that case, because you don't want to start like needlessly getting resistance. So that's why I was saying ceftriaxone is in that sweet spot of empiric, where it's a third generation cephalosporin, but you're not going to the fourth and the fifth generation for like MRSA and all that. That's why you give vancomycin as well, by the way. So the treatment for bacterial meningitis is vanco plus ceftriaxone. Vanco for just in case it's one of those super bugs like MRSA, and then ceftriaxone for the common, the third generation kind of coverage. Do you guys understand what I'm trying to say? If not, I can re-explain it. Okay, great. I'll just to quickly re-explain cefepime. That fourth generation, a little too advanced. It targets more for the Pseudomonas. We know that Pseudomonas doesn't cause bacterial meningitis, all right, or at least not commonly. Tamam? All right, let's move on then. All right, so ceftriaxone is a third generation cephalosporin, has excellent. Also one major thing I forgot to mention is that the CNS penetration in cephalosporin and ceftriaxone is the best. Okay. And you see limited data on effectiveness of cefepime and meningitis. Why? First of all, obviously it's not going to be the same as ceftriaxone. Second, it's not made to target the bugs that usually that cefepime covers. Okay, which of the following antibiotics exhibits a long post-antibiotic effect that permits once daily dosing? First of all, can anyone tell me what is a post-antibiotic effect? PAE. PAE.
I don't really understand, but it was when an antibiotic works below the MIC.
Below the MIC. Okay, you have like a decent understanding. And even below MIC. Yeah, so okay. You're saying you don't understand, so let me try to make it very easy for you to understand. The way to just think about it, post-antibiotic effect simply means which antibiotic can you give to where which one would last the longest after giving it. Okay, so for example, gentamicin, you can give it and then it would still kill bacteria even after you gave it a day ago. Versus, for example, in penicillin, you'd have to give it again after 12 hours. Do you understand? So gentamicin, it lasts a long time. It can kill the bacteria for a long time after giving it. Versus penicillin, you have to give it again after 12 hours. Gentamicin, you can give it a whole day later. It would still be killing bacteria. That's kind of what the post-antibiotic effect means. Post-antibiotic mean after taking the pill. How long does the pill last? How long does it kill the bacteria for? So in this question, yes, it's gentamicin. Gentamicin has a very long post-antibiotic effect, meaning even after taking the gentamicin pill, it'll have a long time. It'll take a long time to not take a long time. It'll last for a long time, killing the bacteria. A lot longer than these other drugs. Do you understand? Yeah, so aminoglycoside is a gentamicin. Sorry, gentamicin is an aminoglycoside. Okay, don't forget that. Yeah, pharma is kind of Chinese. That's why, guys, it's your midterm, so it's a little too late. But generally, what I did for pod, and not only for pod, for the rest of my blocks, is I always started studying pharma. Like pharma was my first lecture that I would cover, so that I would have more times to revise it. Okay. And just for the quick explanation, aminoglycosides, including gentamicin, possess a long post-antibiotic effect, okay? Especially when given at a high dose every 24 hours. These ones have short post-antibiotic effects, the other drugs. So as you guys said, after falling below the MIC, it still does damage. But just to make it not sound Chinese, it's just how long the drug can last doing damage after you take the pill. That's all it is, doing damage to the bacteria. You're saying, wait, what? Is there something you don't understand?
No, I was just confused because there's another drug that sounds the same as gentamicin,
Gentamicin?
which is It's a fluoroquinolone. So I think it's gemifluorosin or something.
Yeah.
It's a little confused.
That's the problem with pharmacology, right? You have gentamicin and then like erythromycin, azithromycin. They all sound the same, but they're not the same drug class, you know? Honestly, there's no like tip and trick for memorizing things like this. It's just pure memorization. That's why I was saying, inshallah, guys, after your midterm, the future pharma lectures you have, always prioritize doing those first, so you have more time to keep redoing those slides. Because there's nothing more than just pure memorization in pharma. And that's why when I was given this lecture to cover for Khalid, I was like, oh, pharma review, that's pretty garbage, because it's either you know it or you don't. And there are some critical thinking questions like that Pseudomonas question where you have to put some pieces together. But usually this is what pharma is, right? And that's the sad part of pharma, is it's very tough. But as a physician, as a doctor, you guys really need to know your drugs. And memorizing the drugs well now will definitely help you out in your future blocks, because these drugs are going to keep coming back. Okay. Is there any other questions? All right. Let's move on. A 68-year-old male presents from a nursing home with fever, increased urinary frequency and urgency, and mental status changes. He has a penicillin allergy for anaphylaxis. Of anaphylaxis. Which of the following beta-lactams is the most appropriate choice for gram-negative coverage of this patient's urinary tract infection? C. Okay, one person says C. Any other options? Or we all agree it's C? Okay, 2 people saying it's C. All right, so yes, it is C. Now, can anyone tell me why? Why did we choose C here? Yeah, so if someone is allergic to penicillin, you have to give a drug that can treat the infection, but at the same time not trigger this penicillin allergy. So there's a nice little graph here. Monobactams, which is the drug that we chose here as Trionam, has the least risk of allergy to someone with a penicillin allergy. Okay. So if someone has a penicillin allergy, you want to avoid cephalosporins because it has about a 10% chance of doing a penicillin allergy. Carbapenems are okay, but monobactams have the least risk. So if you have the option to choose a monobactam when someone has a penicillin allergy, you should go with the monobactam drug. Okay, do you guys understand? All right. So it's a nice little thing. Just try to memorize. Penicillins, bad. Cephalosporins, bad. Carbapenems are okay, but monobactams are the best. So, which of the following antibiotics is considered safe to use in neonates? There's 2 ways to answer this question, right? 2 ways to answer this question. One is just you could purely memorize which one is safe. And 2, you can use kind of some critical thinking. So before I say the actual answer, let's think, right? In a GBS infection, group B strep. Do you guys remember what I told you the treatment for group B strep is? Group B strep or strep agalactia, the same thing. Do you guys remember? Penicillin, yes. So penicillin G. So in a woman that has group B strep infection, while she's pregnant, what do you give her? You give her penicillin G, right? And that I just kind of use that in my head to remember, oh, okay, so penicillin G, if you're giving it to the mother, it's probably safe for the baby as well, because it's just small. It doesn't give any side effects to the baby. And also the main way you should be able to answer this is you can rule out the other options. So A, for sure, is toxic. Yes, like you said. What does A do? What does A cause to babies? There's a specific syndrome, gray baby syndrome, yes. And also, one big thing is aplastic anemia, which is fatal. Okay, that would kill the baby. B, what is B, guys? B is a new drug here that we haven't talked about yet. Well, I'm sure you've taken it because we talk about it later. Anti-metabolite. How would an anti-metabolite be bad for a baby? Let's use some critical thinking. Why would an anti-metabolite be hurtful for a baby? Cartilage damage is one of them, but there's more of a serious thing. Cartilage damage is good. Liver isn't mature enough. Okay. So just the general way to think about it. What do these drugs do? They compete with what? What do they compete with? What do they inhibit? They compete with a certain type of nutrient, not nutrient, like an important thing in the body. Okay, so folic acid, right? Babies, folate deficiency, exactly. So babies are still growing, right? They're still very young. They need to grow. They need the DNA synthesis. When you give a drug that inhibits the DNA synthesis, it leads to reduced DNA synthesis, which is very bad for a growing baby. So that's why just always remember any sort of anti-metabolite for a baby that's growing that really needs this folate, you cannot give it. Okay? Tetracycline, what does tetracycline do to babies? Teratogen deposits in bones and teeth, right? And then we said penicillin's okay. Yeah, bone and teeth, correct. Okay. All right, let's go. A 2-week-old neonate was brought to the emergency room by her parents for constant crying and sensitivity to light. These symptoms correspond with meningitis. No, why is the picture not showing? Okay, that's fine. That's actually fine. These symptoms correspond with meningitis. A gram stain of cerebrospinal fluid revealed gram-positive rods resembling diphtheroids. The antibiotic regimen for the empiric treatment would include which of the following, and what is the causative agent? So just before, I don't know why it's not showing. I think if I press the next slide, it might show. Can anyone tell me first of all, what is this infection? What is happening to this baby? So diphtheria. Okay, so you guys saw the diphtheroids and you thought diphtheria. Now let's remember, guys. Let's remember. Okay, let's not jump to things. Diphtheria is a good option because okay, gram-positive rods revealing diphtheroids. Okay, yes, diphtheria does show that, but there's another bacteria that also shows the same thing. It also shows the same thing, and it's more specific for a 2-week-old baby. What bacteria do you guys think that is? I would be more on the diphtheria side if it was maybe like a kid, like a child, but a baby. Difficile. What can cause? Do you guys know what bacteria can cause neonatal meningitis? No, not gonorrhea. This is a gram-positive. So Agalactia is one of them, yes. But this is not Agalactia because, yeah, so there's another bacteria that's very important for neonatal meningitis. I'll give you guys a couple more seconds and then I'll just say it. No, not in this case. Gonorrhea is not in this case because it's a gram-positive. If it was gram-negative, yes, it could cause it. But we're talking about a gram-positive. So in this case, neonatal meningitis, guys, neonatal meningitis with diphtheroids, gram-positive rods, listeria. The bug is listeria. Okay? You guys know what listeria is, right? You guys haven't taken it? That's interesting. You guys took gram-positive bacteria, right? In detail, no. Okay. Well, I mean, just know listeria, it causes neonatal meningitis in a baby. Okay. Non-spore. Okay, so you guys didn't take it. Well, it's an important bacteria to know for your later thing, so I'll just say it real quick. Neonatal baby with meningitis. It's also associated with drinking milk, unpasteurized milk. The treatment is ampicillin. Okay. Treatment is ampicillin. Diphtheroid-like gram-positive rods in the cerebrospinal fluid is indicative of listeria. It also can affect old people. So old people and babies. And this is the sketchy video for it. I'm assuming you guys didn't watch it since it's not included, but yeah, there's a amp here for ampicillin. Okay, let's talk about the antimetabolites in the fluoroquinolones. First of all, okay, I'll do this picture. So you guys know what cotrimazole is and sulfonamides, the mechanism of action. You guys know all of this, right? Effect goes on this, and trimethoprim goes on this. You put these together, you have a greater effect, right? I want to make sure you guys know this so that when we answer the questions, we'll be able to answer them correctly. Everything good? All right, and these are the quinolones. I don't know if you have to know each generation, which ones covers, which ones don't, but it's kind of the same idea of the more generation you go, the more coverage there is. Okay. Is there anything specific I wanted you to know here? I don't think so. Just read this on your own time. I think it's important to know. All right. So first of all, what is the mechanism of quinolones? Can someone tell me? 50S? Does anyone have any other answers? Yeah, so does not bind to 50S. You're confusing it with something else. Fluoroquinolones. Quinolones, fluoroquinolones. They're the same thing. DNA gyrase, yes. So DNA gyrase and topoisomerase. Perfect. So did you guys know that DNA gyrase is for gram-negative bacteria and gram-positive bacteria? It's more of the topoisomerase. Okay. So in gram-negative bacteria, you inhibit the DNA gyrase. Gram-positive bacteria is the topoisomerase. The way I memorize it, DNA, the N in DNA is for negative, and then topoisomerase, there's no N there, so it's for the gram-positive. That's how I memorized it. But you guys, obviously, you can memorize it your own way. Okay, so you have DNA gyrase and you have topoisomerase. How do you think the resistance to fluoroquinolones can happen just in general? How can fluoroquinolones develop how can bacteria develop resistance to changing the enzyme? Okay, so changing the enzyme is one way. Which enzyme? Both, right? Both enzymes could be mutated. So yeah, exactly. So that's one way. What are the other two ways? And these other two ways, you can find it with the other drugs as well. They can kick out the drug, yes, using an efflux pump, right? So that's the next slide here. So the ways you can have resistance, mutation of the enzymes. The enzymes can be mutated. Obviously, if the enzyme is mutated, what happens? The drug won't be able to bind to the enzyme if it mutates, okay? Another way, if the bacteria doesn't let the drug come in, that's a mutation. Can't let it come in, that's one way to get resistance. Another way, if the bacteria develops a pump that can pump out the drug after it goes in, before it can exert its effect, that's resistance, okay? So efflux pump and decreased permeability, you can see that with the other antibiotics as well, by the way, but not as much in here. Fluoroquinolones is very, resistance to fluoroquinolones is a very high yield topic, and you should know it well. And then obviously you have the mutations to the enzymes. Okay. And just before we move on, I wanted to ask guys, how come there's not resistance, or sorry, not resistance, how come there isn't that many side effects to humans if DNA gyrase and DNA and topoisomerase is being affected? Why is it not toxic to human cells? Different structures. Yeah. So humans, we have, topoisomerase 2. Exactly. So this is topoisomerase 4. In humans or mammals, we have topoisomerase 2, which has a lot less affinity to bind to these fluoroquinolones, hence why we can tolerate these drugs. That's good. Thank you very much. All right. These are our last questions. Okay. I got these from Amboss. A microbiologist has isolated several colonies of E. coli on an agar plate. The microbiologist exposes the agar plate to ciprofloxacin, which destroys all of the bacteria except one colony. Which of the following is the most likely mechanism of antibiotics in this colony, guys? What's happening here? What is happening here? Okay. You're looking at the question a bit differently. So yes, I know what you're talking about, how ciprofloxacin affects everything but strep pneumo. But here it's saying that this bacteria, this one surviving colony of bacteria, how is it alive? It's alive because it developed resistance to the ciprofloxacin. So the question is asking how did the resistance happen? What changed in this one colony of E. coli that caused resistance? Okay. Yes. So two people are saying B. Does anyone have any other options? So you see how they can ask these very simple concepts. I just taught you this very simple concept of resistance. You see how they can twist the wording and make it a bit confusing? That's why doing questions, guys, is very important. Inshallah, your exam's on Sunday. I hope you focus on doing your questions. Do a lot of questions. You'll train your brain on how to answer them, inshallah. Okay? Doing these questions is very good. It's very good for refining that information, inshallah. So the answer is B. Chromosome-mediated mutations in DNA gyrase and topoisomerase is a common bacterial resistance to fluoroquinolones. We basically talked about this. I don't think I'm going to take too much time on it. Does anyone have any questions? Okay, we'll move on then. Is there questions for equations such as the bioavailability? I'm not sure how to use them. That wasn't part of my lecture, to be honest. I didn't prepare anything for bioavailability. I can't remember if I even had them in my exam. So I don't want to exactly teach you anything wrong. The thing is too many drugs. Each one with its own side effects and stuff. Generations, there'll be questions, as the doctor said. Yeah, I mean, see, that's the thing, right? You gotta, if you do your past exams, do the academic aid past exams. See, the past exams is very important, guys. I'd rather have you go into the exam and do your past exams than do the lectures if you haven't done the lectures yet. The past exams are very important. Why? Because you'll get an idea of what like side effects they might ask about, right? Sometimes they ask about the most very stupid, ridiculous side effect, something they wrote like in a very small slide, or sometimes it's not even mentioned. And that's just the sad part of pharmacology. Sometimes you'll get a question wrong from that. Sometimes you'll get a question that, the doctor didn't put it in the slides, but she said it in the lecture, and this happens sometimes. And honestly, like the only way you can combat this, and the way I combated it and got good grades, alhamdulillah, is I would always prioritize doing my pharmacology questions or pharmacology lectures. I just did them so many times that by the time I went into my exam, I had looked at each PowerPoint like at least 5 times. Pharmacology in specific. Everything else, I could do it once or twice. It's fine. Pharmacology is it's just a very tough thing, especially in POD and neuro. You'll see neuropharma is very tough as well, but neuro and POD pharma, it's a very tough subject because it's very dense. You have all these drugs, all these side effects. The only way to really combat it is pure memorization. Anki's good. I personally, what I would do is I would like print out these little tables that Maryam Tayyib did. I'm sure you guys have them too. And I would just kind of read the tables right before going into my exam. Just quickly get down there's the common and then the uncommon. You really want to know the common. The uncommon, whether you know it or not, it's it'll come in the exam. It's your luck, right? But inshallah khair. So I'm sure you guys are answering these questions very well, mashallah. Even like the tricky questions, some of you got it wrong once, but then you quickly corrected yourself. You guys are gonna be fine, inshallah. You got this. All right, let's move on. We don't have that many questions left. Next question. This one's a bit long. So these AMBOSS questions, they like to put in a lot of useless stuff. And I wanted to put these questions for you guys because you're gonna start seeing this in POD and further on. Okay. They like to give you these long, scary questions. And then it's going to have a lot of stuff that's useless. You need to be able to filter out what's useless and what's important to you. Okay. So let's go through this question. A 42-year-old woman comes to the physician because of pain in her left ankle for 2 days. The pain is worse at night and with exercise. 5 days ago, the patient was diagnosed with salmonella, gastroenteritis, and started on ciprofloxacin. Okay, so the drug is ciprofloxacin. She has ulcerative colitis, hypertension, hypercholesterolemia, and has smoked 2 packs of cigarettes daily for 25 years and drinks 2 to 3 beers daily. Current medications include mesalamine, hydrochlorothiazide, and simvastatin. I don't think you guys have to worry about this. You don't know them, so just ignore it. She is 158 centimeters. Vitals are fine. Tenderness above the left posterior calcaneus and mild swelling. Okay, so this is something important. There is tenderness above the left posterior calcaneus and mild swelling. There is normal range of motion of the left ankle, blah, blah, blah. Calf squeeze is not illicit, plantar flexion. We don't really care about all this. Which of the following is the most likely mechanism of this patient's symptoms? Okay, we have this huge paragraph. We're like, okay, what do they want? Let's look at it. So you as a second-year medical student, you're taking pod. You see fluoroquinolone. Okay, fluoroquinolone. And what else do you guys think is relevant in this question? The patient is taking ciprofloxacin. What else do you think is relevant in this question? The answer is very obvious because we're taking a pharmacology lecture. So obviously, I think the answer is obvious, but I want you guys to know why this is happening. Yeah, so the answer is A, adverse medication effect. But I want to know what's happening, guys. What do you think is happening to this patient? You guys know what this means? The left posterior calcaneus and mild swelling. You guys know what the side effects for ciprofloxacin is? So edema, okay, I see what you mean. I'll give you guys a second to think about it. I need to quickly do something. Bone and something. Just give me 1 second, sorry. Okay, I'm back. Sorry about that. So bone and something, yeah, that's pretty much what it is. You have in fluoroquinolones, a rare side effect, tendinopathy. Okay. So when the question says, oh, there's left posterior calcaneus mild swelling, that just means, okay, there's the tendons in this guy is a bit in pain. And that's another thing. Yeah, exactly. Bone in children and tendon in adults. So that's another thing you need to know. You hear the word, you read the word tendinopathy, you should know, okay, the presentation for tendinopathy. What is that? Tendon rupture. It could be that as well. Yes. So you should know these things. Okay. You should be able to recognize it in a question. Does anyone have any questions for this part? All right, let's move on then. Another big question. Okay. 56-year-old woman comes to the physician because of a 2-week history of fatigue and painless bruising over her arms and trunk. She has also had several episodes of nosebleeds that resolved with compression after a few minutes. Oh, sorry. Oh, that was a spoiler. She recently completed treatment for a urinary tract infection. She has no changes in her weight. She has type 2 diabetes and hypertension. Her last menstrual cycle was 5 years ago. Does not drink or alcohol. Medications include medications we don't care about. Vital signs are normal. Physical exam shows pale conjunctiva. There's ecchymosis and petechia over the upper extremities, chest and back. There is no lymphadenopathy, and this is the lab results. So just so you guys know, the lab results are showing low hemoglobin, low white blood cells, low platelet count. What is happening to this patient, guys? Tell me. Forget what the question is asking. Okay, aplastic anemia. Perfect. So this patient is having aplastic anemia. Now, what is causing the aplastic anemia? What in this question stem gives you the hint that this person is taking something that might have caused aplastic anemia? Okay, so that's one of the drugs. Yes. But now, see, this is very tricky, right? I want you to catch this. She recently completed treatment for a urinary tract infection. Do you guys know which of the fluoroquinolones or antimetabolites, any of those drug classes, which ones do you give for a urinary tract infection? 5th generation. No, so there's one specific thing. Remember the cotrimazole I was talking about? The TMP SMX? Trimethoprim and the sulfonamide with trimethoprim. Do you remember that? So in UTIs, remember this. In UTIs, you usually give this drug, okay? And one of the side effects of this drug could be aplastic anemia. So the question here is asking, what do you do to confirm the diagnosis? This is like a step 2 thing. Don't worry about it, but you would do a bone marrow biopsy. But what I want you to get out of here is aplastic anemia is a complication of sulfonamide treatment, the sulfamethoxazole and trimethoprim, the 2 ones, the cotrimazole. It's another word for it, okay? This can cause aplastic anemia. And the reason we assume that's what's happening here is because we saw that she was getting treated for a urinary tract infection, okay? So what do you remember? Urinary tract infection. Usually you can give sulfamethoxole with trimethoprim. What can this cause? It can cause aplastic anemia, and it can also cause other things, but I need you to memorize that on your own time. Okay, guys? Do you get this? It's a bit of a harder question, but I wanted you to get this in your head. All right? Perfect. All right, next question. A 6-year-old boy is brought to the physician because of headache, cough, runny nose, and a low-grade fever since waking up that morning. He's been healthy except for a urinary tract infection that was resolved with trimethoprim and sulfamethoxole therapy. All right, so this is something we talked about already. Both parents have a history of blah, 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 all this stuff we don't really care about. It's just giving you more extra information. And then here, okay, the white blood cells are low. The white blood cells are low, okay? Which of the following is the most likely cause of this patient's findings? Very similar to the previous question, to be honest. Okay, so yeah, now see, B is kind of like a trick answer. Why is B a trick answer? Because you know that, yes, it can cause folate deficiency, but folate deficiency, honestly, this is a bit like a little too advanced, but it's essentially, you know what agranulocytosis is? It's just generally granulocytes are like your white blood cells, okay? Agranulocytosis means your white blood cells are down. This drug, which can cause aplastic anemia, can also cause agranulocytosis, okay? And this can present, so if the question shows a kid that he's getting sick a lot, that's what agranulocytosis usually presents with, okay? And just remember, TMP, which is this drug, trimethoprim sulfamethoxole, or the cotrimazole, TMP treats the bone marrow poorly, treats marrow poorly. Okay, so I put two questions of the same concept because I wanted you to remember that this is a very serious side effect of trimethoprim, blah, blah, blah. And it's also in your, this is from your slides as well. You have these other things. You have connecticus, hemolysis, hepatitis, photosensitization, Stevens-Johnson syndrome, crystalluria, fixed drug reactions. There's a lot of things that can go wrong. But yeah, okay. Do you guys have any questions about this? Do you have any questions about like the lecture in general? Because that was the full thing. And I want to look up that penicillin thing for you guys. But just quickly, could you please fill out the feedback form, because GND asked me to share this with you for feedback in terms of the lecture itself. And I hope inshallah you guys benefit out of this. If you do have any questions, please feel free to ask me. You can email me or text me. I'm a 5th-year medical student. I can help you with any subject. I'm always here to help people. I hope my lecture was good. I apologize. It wasn't the best lecture. I was kind of given short notice for this, but I think it was still good. Alhamdulillah. I think you guys hopefully took a lot out of this. And if you guys have any more questions, please let me know. And if you want to just wait like a couple minutes, I'm going to quickly search up this penicillin thing just so you guys come out with the right answer. Okay, just give me a second. I will find you the answer.